ايوه تيست مايك. هلا تيست. البوديوم كده جربه.
Hello, test. Hello, test. Hello, test. Mic, test.
ايوه تيست ايوه تيست مايك. ايوه بسم الله الرحمن الرحيم. ايوه تيست مايك. بسم الله الرحمن الرحيم. ايوه تيست مايك. تيست ايوه تيست مايك.
تسلم. محمد لما تبقى جاهز قول لي لو سمحت.
هو شغال.
السلام عليكم. بسم الله الرحمن الرحيم. Thank you all the attendees. Today is our MDT meeting about management of lung cancer in the COVID-19 era. I'm Dr. Ahmed Gaballah, Assistant Professor of Clinical Oncology at Shams University. I am a co-founder of the EMOG group. I will give a short presentation about our group and the scientific meeting. Actually, the idea of the EMOG group arose from the EMRO WHO group, which includes all the North Africa, Arab region, Gulf, and part of Asia. This group aimed at making an MDT oncology committee in the Arab region between Egypt and Gulf region and North Africa, including all the medical oncologists, radiation oncologists, pathologists, radiologists, surgeons, and different aspects of doctors that are interested in the care of cancer patients. We are now in the phase of registering our group in the ministry in Egypt as an NGO. This group aims at collaborative work among the oncology interested groups in the region to provide a continuous medical education module. This module, inshallah, will be in a multidisciplinary teamwork. You can check all our previous events of the EMOG group in our YouTube channel. This is the link. We'll send it in an email, or just you can put in the channel search Eastern Mediterranean Oncology Group EMOG, and you will find all our scientific activities. In the near future, inshallah, we will start and participate in multicentric, multidisciplinary oncology researches. We invite all our colleagues in Egypt and in the Arab region to join us and to join the scientific activities. And any doctor who is interested to join the group, just send us an email at emog2021@gmail.com. Today is our sixth educational event, EMOG Lung Cancer Symposium, Lung Cancer MDT Management and Challenges in the COVID-19 era. The faculty of the event alphabetically, Dr. Abdel Fattah Touman. Dr. Abdel Fattah Touman is a consultant pulmonology and intervention pulmonology at King Abdullah Medical City, Mecca, KSA. Dr. Ahmed Hassan. Dr. Ahmed Hassan, consultant clinical oncology at Shams University, and he is a locum consultant clinical oncologist NHS England. Dr. Hani Hassan Al-Sayed is a professor of thoracic surgery, head of department at Shams University. Dr. Maya Azzeddin is an assistant professor of clinical oncology, faculty of medicine at Shams University. Dr. Muhammad Al-Nadi, professor of chest disease, Cairo University, and he is the director of chest unit, Newcastle Al-Aini Teaching Hospital, and he is a member of the COVID-19 Scientific Committee, Egyptian MOH. Dr. Salim Al-Shehri, consultant radiation oncology at King Abdulaziz Medical City, National Guard Hospital, Riyadh, KSA. I would like to express my deep thanks and deep gratitude to Eva Pharma for sponsoring this event, and a special thanks to Dr. Rihab and Dr. Michel. And thanks to the organizing committee, Worldwide Academy. Inshallah, our next event, which will be the seventh event, will be EMOG IO Symposium, This symposium will be in collaboration with King Faisal Hospital in Riyadh, inshallah, and it will be in the 25th and 26th of March. Thank you. And now I'd like to present our first speaker, Dr. Abdel Fattah Touman. Dr. Fattah Touman is a consultant pulmonology, intervention pulmonology at King Abdullah Medical City, Mecca, KSA. Dr. Abdel Fattah, please. Dr. Fattah.
Good afternoon. Yeah, good afternoon. I can't see my slide. So today I have the task to discuss diagnostic and staging approach for lung cancer from the interventional pulmonology perspective. Next slide, please. So, as introduction, interventional pulmonology usually is asked to do one of three things in regard to the thoracic oncology, either to diagnose a case or stage or to have therapeutic intervention. Under the diagnosis, it might be a challenge to diagnose pulmonary nodules or masses, or to diagnose a mediastinal or hilar adenopathies, or the patient might be already diagnosed and the request is to have more tissue for molecular analysis. In regard for therapy, it might be a central airway tumors or malignant nodules. In today's talk, I will discuss the diagnostic and staging role of interventional pulmonologists. However, I will not mention anything about the therapeutic possibilities. Starting with the diagnostic roles of nodules and a mass, simple definition. Fleischner Society defined nodules as a rounded or irregular opacity, which is a well or poorly defined, which is measuring up to 3 centimeters in diameter. In 2010, American National Lung Screening Trials has shown a 20% reduction of the lung cancer related mortality by using a low-dose chest CT in a high-risk group of patients. Guidelines from many scientific societies adopted this policy for lung cancer screening. So applying low-dose CT will cause a reduction in mortality. However, in 27% of patients who underwent screening, they had at least one nodule which is more than 4 millimeters. So for this nodule, we have to either biopsy or follow up radiologically. So it solved a problem, and at the same time, it created a problem for the interventional pulmonologist, oncologist, and thoracic surgeon. The clinical and organization factor guideline from chest American College of Chest Physicians have a stepwise approach in regard to diagnosis of the lung cancer, starting with the initial evaluation of patient, whether he is known or suspected to have lung cancer. We usually start with a history and physical assessment of the patient. We assess his comorbidities, functional status, the patient preference for different modality that we will offer him, the evidence or not of distal metastasis. Then we go for the physiological and laboratory assessment. Our physiological assessment for the patient lung function include pulmonary function test with diffusion of lung CO, and it might include cardiopulmonary exercise test if the patient have borderline pulmonary function test, complete blood count chemistry, calcium level, liver function test, imaging, whether we have CT or CT PET. And if the evaluation and the treatment of paraneoplastic syndrome is to be considered once suspected. Once we finish our initial assessment for the patient, we go for the next step of our diagnostic algorithm, which is diagnose and staging of the patient. We start with the probable distal metastasis if it is suspected. We go and sample it. We usually have to sample the most accessible lesion, which will provide the most advanced stage for the tumor with the least risk. If we reach our diagnosis and staging in the same session, so our diagnostic and staging step is finished, we go directly to the treatment. Should be in context of multidisciplinary treatment based on comorbidity, the patient functional status, histology and molecular marker, the patient stage and patient preference. However, if there was no distal metastasis, we look for the N1 for the mediastinal lymph adenopathy, whether it's N1 or N2 or 3, by CT or CT PET, and we go for biopsy of those lymph nodes, whether we have mediastinoscopy or EBS-TBNA, and I will go in detail within the few next slides. If we reach diagnosis, we go to the treatment. However, if we don't, we try to biopsy the lesion itself, and once we confirm our diagnosis, we go back to treatment. Here, if we did not reach to diagnosis, whether we sampled the distal mets or the mediastinal adenopathy, we go back to the list stage. For example, if we find a lesion in the liver and it turned to be not related to the current malignancy, let's say it was confirmed to be benign entity, we go to that to have our biopsy from the mediastinal adenopathy, and this is applied again for patients who we suspect that he have mediastinal adenopathy, and we confirm that it was negative, so we go directly to biopsy the patient mass itself. This usually happens in the same session of bronchoscopy. So nodules or mass can be classified to endobronchial masses or tumor, which might appear as an ulceration or induration in the airways, or more defined masses, which can be vascular or can be extremely necrotic. With the necrotic lesions, we might have inconclusive biopsies due to the extensive necrosis. However, overall sensitivity for endobronchial biopsy is approaching 90%, and the number of biopsies should be taking multiple biopsies in order to have the molecular testing and enough material for molecular analysis. The challenge came with the peripheral lesions. In the peripheral lesion, there is different approach to depend on the facility available in institution. However, we have the bronchoscopic approaches for solitary pulmonary nodules peripherally located, and we have the transthoracic CT guided or ultrasound biopsies. In the American in the publication of CHEST 2013, there is a nice guidelines and algorithm in a patient with a low risk for surgical intervention, and if we have high risk for and high probability of the nodule to be malignancy. So here we are talking about a nodule between 8 to 30 millimeter in diameters. The next step can be standard staging evaluation using CT or CT PET, and if there is no distal metastasis, we can go for surgical resection in a high-risk patient, even if we did not sample it. However, if we decide to sample a lesion because we are not sure whether it's malignant or not, I will start discussing the sensitivity for the CT-guided transthoracic needle aspiration. So our magic number is 90%. The overall sensitivity for these nodules is 92%. The diagnostic yields remain high even if the nodule is less than 2 centimeters in diameter. However, this high diagnostic accuracy came in the cost of high complication. So there is only 3% bleeding complication, and there is 20% pneumothorax risk, and 7.3% of those 7.3% require chest tube insertion. What about bronchoscopy? Bronchoscopy, there is many factors which manipulate and increase or decrease our yield. The size of the nodules, the location of the nodules, the presence or absence of the bronchial sign, the nature of the pulmonary nodules, what type of sampling technique we use. The higher diagnostic use came with the transbronchial needle aspiration followed by transbronchial biopsies, and the number of biopsies, the more we took biopsy, the more likely that we have positive diagnostic procedure. Up to the 6th biopsy, after that the diagnostic accuracy plateaued. So it's not advised to go without a navigation system if we could not find the peripheral nodules, so we cannot go to the airway doing bronchoscopy, then randomly fishing different airways with random biopsies. So if the overall sensitivity of bronchoscopy under fluoroscopic guidance is 78%, it's lower than the CT-guided transthoracic needle aspiration. However, our sensitivity dropped significantly once the nodule is less than 2 centimeters in diameter. The complication risk for bronchoscopic procedure is very low. It's less than 1% for the pneumothorax and almost 1 to 4% with clinical significant bleeding. The other modality that bronchoscopy might use to increase his diagnostic yield is the radial probe EBUS. So the concept behind this, it's a small probe that you can pass through the working channel of your bronchoscope. After you wedge your scope according to your previous study on the CT scan, then you will pass the extended working channel and you turn on your ultrasound, and it will give you the exact, it will give you an image which will guide you whether you are inside a normal lung tissue or you are inside the tumor. Once you are inside the tumor, you retract your ultrasound, you fix your catheter, then you apply different sampling technique, whether you want to use the needle or biopsy. So the overall sensitivity of this technique is 73%, and it increased the diagnostic yields once we have a small nodule less than 2 centimeters. For the complication, I will not just go repeating that bronchoscopic technique is very safe with less than 1% risk of bleeding and pneumothorax. So here is 4 different images of radial probe EBUS. Here we can see that the probe is in the middle of the tumor itself. So if we find this image and we applied our biopsy, our diagnostic yield will be in the range of 83%. So it's above 80%. So we have a good diagnostic sensitivity. However, if the tumor, we couldn't reach to the center of the tumor and we are always adjacent to the tumor, no matter how we try to position our scope in the middle of the tumor. So in this situation, if we apply biopsies, our diagnostic yield will be in the range of 60%. However, if we couldn't locate the tumor and we have normal lung tissue image by the ultrasound and we try to have a random biopsy, the diagnostic yield will be only 4%. So it's not advised to have a random biopsy unless you find the tumor or nodule that you are looking for. And it have a possibility to show you the vessels which might cross near to your sampling location. So the American College of Physicians is recommending this technique in its latest guideline. So it's mentioned that in patients suspected of having lung cancer who have peripheral lung nodule and tissue diagnosis is required due to uncertainty of diagnosis or poor surgical candidacy, radial EBUS is recommended as adjacent imaging modality. This is a grade 1C recommendation. What other techniques that we can use? So I fixed the gold standard, the highest yield of the CT transthoracic needle aspiration, and I will just mention the different bronchoscopic beside to this high yield procedure. So if we combine the virtual bronchoscopic navigation with the radial probe EBUS, so we have our CT and we studied our patient with reconstruction image and navigation to the desired location. Then we went with the endoscopy and we confirmed our location using our radial probe EBUS. So our diagnostic yield will improve by up to 80%, and it will improve more when we deal with the small nodule less than 2 centimeters. So our diagnostic yield will reach 75%. The complication is also less than 1%. So some might think, why not to do the virtual bronchoscopic navigation imaging and to plan our procedure, then go directly with a small scope. So any scope with less than with less than 3 millimeter outer diameters is ultra thin bronchoscopy. So why not to go with the ultra thin bronchoscopy instead of inserting a radial probe and visualize that peripheral nodules and take biopsy directly from it. So if we did this technique, if we use the combination of visual bronchoscopic navigation with ultra-thin bronchoscopy, the diagnostic yield will drop instead of increasing. Why is that? Because when you use smaller scope, our working channel, which we pass our forceps and diagnostic tool from it, will be smaller. As we use smaller bronchoscopy, the working channel that we use will become smaller and smaller, so we will have smaller, although we have seen the nodules and we biopsy the nodule directly, but because we use smaller tools, the diagnostic yield will drop. And this apply again, even if we confirm our location before taking the sample using the radial probe ultrasound. So in this arm of the table, it's a 3 different technique used. They plan the procedure using the virtual bronchoscopic navigation, and they use the ultra-thin bronchoscopy with less than 3 millimeter outer diameters. They confirm their position with the ultrasound before they took biopsy. However, the diagnostic yield remained low because the small scope gave us smaller sample, which might be not enough for diagnosis. What about the electromagnetic navigation? So the overall sensitivity for this technique, in brief, it's a new modality where the navigation system will guide you like the GPS system in your car will guide you through the road. This system will guide you through the airway, and it will inform you once you reach to the nodules, and you can take different biopsy from the same nodules. So the diagnostic yield is in the range of 77%, and it also do good when we deal with the small nodules of less than 2 centimeters in diameters. And if we combine both the electromagnetic navigation, the real-time navigation system using the electromagnetic field, plus before we took our biopsy, we confirm our location with an ultrasound probe, we reach the magic number of 90%. So combining electromagnetic navigation with radial probe EBUS give us almost similar diagnostic accuracy to the CT-guided tBNA. However, the cost is much higher in using these different bronchoscopic modality. But here we have a very low risk of complication. And in the CT-guided biopsy, we are feeling of pneumothorax and bleeding. So how can we use between these different modalities? Simply, two important factors. If we have to take a tissue diagnosis before we have to decide our therapeutic management, we have to ask ourselves, is the patient have severe obstructive airway disease and emphysema? These type of patients who have the highest risk of complication using CT-guided or ultrasound-guided peripheral transthoracic biopsy. The second question we have to ask ourselves, if the patient have mediastinal involvement. So if the patient have mediastinal involvement, we always prefer to diagnose and stay in the same setting. So bronchoscopy will be always the first choice. So whether if the patient have emphysema or he has mediastinal involvement, so it's advised to go use one of the above mentioned bronchoscopic modality. If the patient does not have emphysema and the patient does not have mediastinal involvement, it's only solitary pulmonary nodules peripherally located without mediastinal involvement, so it's safer and have very high diagnostic accuracy if we send him for CT-guided biopsy. And for the next part of the diagnostic talk, mediastinal hyaluronadenopathies, we sample the mediastinal and hyaluronadenopathy using transbronchial needle aspiration. It's a minimally invasive procedure that provides a non-surgical means to sample tissue beyond the vision of operator. So the sample will be through the trachea and bronchial wall as example for the mediastinal nodes. We have two TBNA methods, the conventional method. So this is a CT showing enlarged R4 lymph node with central necrosis. So the operator will go blindly, he will liquid the carina and he will go 1 to 2 space and he will just insert the needle within the regular scope in the location between 1 and 2 o'clock, and he will sample this location. So this location is correlating with the station 4R. So this is a cheap technique and well known. The modern technique is to use the ultrasound guided transbronchial needle aspiration. So basically the operator will go with the ultrasound bronchoscopy and he will try to locate the lymph nodes. So in this example, the operator is trying to locate 4L, which is between the pulmonary artery and the aorta, which what's called the Mickey Mouse sign here, two rounded major vessels, and he locates this small 4L lymph node. Then he passes his needle and the direct ultrasound guidance, and he agitates his needle to obtain the tissue. So, why not to use this technique to solve our problem of sampling the small peripheral nodules? Back to the problem of the small nodules. So here is a preliminary trial which was shared in the European Respiratory Congress 2018 in a 61 patient with a bronchoscopically invisible lesions, meaning we dealt with the peripheral nodules. The mean size of the nodule was 25 millimeters. And from those patients, we screened the mediastinal using the EBUS, and all lymph nodes which found to have 5 millimeter and above diameter, we sampled them. From this technique, we managed to diagnose 25 out of this 61 patient with a diagnostic accuracy of 41% and through the mediastinum. So what I want to say that when we deal with a peripheral lung nodule and we screen the mediastinum, we biopsied all enlarged lymph node more than 5 millimeter, and I have to remind you that 5 millimeter is considered radiologically negative. So radiologists will call it enlarged lymph node if it is more than 10 millimeters. So 5, 6, 7, 8, and 9, we biopsied these mediastinal lymph node, and we managed to diagnose 40% of those patients. So here, in the same setting, in the single bronchoscopic procedure, we diagnose patients and we stage them in the same setting. What about the molecular diagnostic? So, does our needles give us adequate sample for molecular diagnostic? So this is a systematic review. Will answer this question. So in this systematic review, 33 studies were included. It included more than 2,600 patients. EBS-TBNA pooled probability of obtaining sufficient sample were 94.5%. For EGFR mutation confidence interval were 93 to 96%, 94.9%. Poor sensitivity for ALK mutation with the data for ROS1 and PDL1 mutation were not suitable for meta-analysis simply because there was no enough studies. For ROS1, there was a single study looked for ROS1 mutation, and this study included 12 patients, and they managed to diagnose. It was positive in 10 out of 12 patients. They have sufficient sample. Their diagnostic yield was 83.3%. For PDL1, only 2 studies studied the possibility of doing the PDL1 on the TBNA cases. So in first study, it was only 23 patients, and PDL1 more than 50% were diagnosed in 3 out of the 23 patients. So what about rebiopsy in case of treatment failure? So this study looked to this question. In particular, there was 70 patients with non-small cell lung cancer who developed resistance to standard chemotherapy or target drug. 18 rebiopsied by EBS-TBNA and 52 with transbronchial biopsies. All EBS-TBNA cases resulted of diagnosis compared to 83% with transbronchial biopsy. Genotyping was possible in all cases. 1 patient showed small cell lung cancer transformation. This is another study looking for the same topic. So molecular analysis was required in 53 patients of non-small cell lung cancer previously treated with tyrosine kinase inhibitor who developed resistance. 9 patients underwent EBS-TBNA and 44 patients underwent radial probe EBS with transbronchial biopsy. The EBS-TBNA was successful to give us adequate sample in 100% of patients. So I remind you, yes, it is 100%, but the number of patients is only 9. What about staging? Rapidly, because I think I'm out of time. So as we know, there is different station of mediastinal nodes. Some of them can be sampled using the EBS, which is station 2, 4, and L, and 4 right and left, subcarinal lymph node, hilar, and the remaining station 8 and 9 can be biopsied using the endoscopic ultrasound through the esophagus by our colleague in gastroenterology.
Dr. Toman?
So yes?
Time, please.
Okay, so I will try to cap. So we have 4 types of lymph node. Not all of them we can, we have to biopsy to stage. In radiological group A, which is a matted node, we don't have to sample the mediastinum. And if we have peripheral small nodules, we should not go for the mediastinal sampling on assessment. However, if we have discrete lymph node in the mediastinum, radiological group B, or we have central tumor, we have to go for mediastinal assessment using TBNA. This table shows different diagnostic sensitivity for different modality. Just I want to highlight that CT and PET scan show CT PET scan have 63% positive predicted value and 90% negative predicted value, and EBS-TBNA has negative predictive value of 90% equal to to the PET CT and have 100% positive predicted value. So this is a 4 different study showing patients with less than 1 centimeter nodules. So these are called radiologically negative lymph nodes, and the investigator went for these lymph nodes and biopsied them. Here we find that they find 13% positive nodes in 2 and 3, and just I will show you this study, which is the patient have radiologically negative CT, PET. And once it was biopsied using the ultrasound, the 9% of them were positive for malignancy. So the guideline mentioned in patients with high suspicion of N2 and 3 involvement, EBUS ultrasound is recommended. Even if the CT PET is negative, if the patient is having tumor more than 3 centimeter or centrally located tumor, we should assess him using EBUS ultrasound. So what about restaging? This is my last slide. So if we want to restage patients, we have lower diagnostic accuracy. The negative predictive value, it's range between 20 to 88%, and that might be due to necrosis and fibrosis of the lymph node after chemoradiotherapy. So we have still ultrasound is not the best modality to restage patient after giving chemoradiotherapy. And by that slide, I conclude my talk.
Thank you, Dr. Fatah, for this nice presentation. Thank you for your time to prepare this. We will have the discussion at the end of the session, inshallah. Now let me introduce Professor Hani Hassan. Professor Hani is a professor of thoracic surgery and the head of department at Faculty of Medicine and Shams University. Dr. Hani is one of the pioneers of thoracic surgery in Egypt. He will introduce for us today surgery for early stage non-small cell lung cancer. How good can it get? Dr. Hani, please.
Thank you for this kind invitation, and it's a great pleasure to be in this lovely meeting here. And it's great to see my friend Dr. Tuman. I haven't seen him for some time. We had some electronic meetings. So he gave us a great presentation, very great high technology there. I have to congratulate him. And I'll show you as surgeons that we just have less technology. We just take it out. So, so surgery for non-small cell lung cancer. I'll give you a bit of a flavor about what we do as surgeons, and we'll discuss something about neoadjuvant chemotherapy. So this is just a summary of what I think is the plan for most patients with non-small cell lung cancer. If a fit patient is in stage 1, he'll probably almost always need surgery. And in most instances, it's only the only treatment needed. In stage 2, yes, the majority of patients will need surgery. And the evidence is that most of them will benefit from some adjuvant treatment, usually in the form of adjuvant chemotherapy. In stage 3 lung cancer, it's only occasional that you operate on patients. And it always will be in the context of a multimodality therapy. There is no one treatment which can cure these patients in stage 3. And it's very rare to need surgery in stage 4 lung cancer, except if you're palliating your patients. These are the lessons I've learned from the new TNM classification, which has been out there for some time now. But I think these are the main lessons we as surgeons have if we look at the new classification. So it really respects size. So every centimeter will count. And that's revived the whole T staging. Not all metastatic lung cancer is the same. Yes, now we've got stage 4A, 4B, and 4C, so there are different stages, and they're not all the same. And I think that thoracic surgeons will operate on more advanced stages of lung cancer with the new TNM classification. So stage 3A, as you can see, this is the main stage where the debate lies, and we'll talk a bit about it more today. But I just want to orient you that stage 3A lung cancer was historically linked to N2 disease. And if you look at the 5 possibilities of stage 3A lung cancer, only 2 of them, tumors which are on a T1AC N2 and T2AB N2, these are the only N2 diseases linked to stage 3A. But the other classifications are advanced T stage, so T3N1 and T4N0 and N1 are labeled as stage 3A. So I just want to enlight that stage 3A is not only N2 disease now, it is locally advanced lung cancer. This is a type of resection we perform. The classic operation for lung cancer is a lobectomy. It's been there for more than 3 decades now, and it's still the classic operation, and probably the best if the patient is fit for it. If it's a central tumor or a large tumor, then you're going to take the whole lung out if the patient can withstand that, and that's a pneumonectomy. And the 2 resections on the bottom, those are a lot of debate around that now. So an anatomical segmentectomy and a non-anatomical wedge resection. So if you're going to remove a segment of the lung with its blood supply and bronchial supply, that's a segmentectomy. That's an anatomical resection. That may carry a better prognosis than if you do just a wedge resection. You take part of the lung out without respecting any anatomy. So in early stages, it's always easy. You've got a patient with stage 1 lung cancer. That's an easy resection. It's an easy decision if the patient's fit to send him to a surgeon. It can get a bit more advanced, and you can see this is a more central tumor causing a collapse of the left upper lobe, and it's associated with an N1 node. So this patient could have surgery, could have a complete resection, but will definitely need adjuvant treatment to achieve cure. And this is the everlasting debate. Well, I've been attending MDTs for the last 15 years, and if you find a patient like this with an N2 disease, and we're in 2021 now, there's still no consensus on how to manage this patient in the best way. But again, these patients may benefit from surgery. If there's a complete resection, they can either receive neoadjuvant or adjuvant chemotherapy, but it's always a multimodality therapy. These are the easy ones. So you've got a peripheral small tumor. The standard of care is still lobectomy, and we've got evidence from this, as I said, more than 3 decades ago. If the patient's not fit, then they can have a sublobar resection. And if you're considering something less than a lobectomy, there's always a debate between a wedge and a segmentectomy. And there's a debate now whether a wedge is superior to stereotactic radiotherapy or not. And obviously, again, there's an ongoing debate outside the scope of this lecture. Just want to let you know that the concept has a bit changed over the last couple of decades for us as thoracic surgeons, because the assumption is that when you take part of the lung out, the patient will breathe worse. And obviously, this is the case in the majority of cases. That's why you perform lung functions, you have a look at the patient's performance status, and a number of other tests to assess fitness. But we have another concept that we put in mind as surgeons, is that there's one common risk factor for emphysema and lung cancer, which is smoking. And a lot of these patients with lung cancer, they have some emphysema in their lungs. And if the lung cancer lies in the same zone as the emphysema, then sometimes you can operate on patients, take part of the lung out for an oncological purpose and to improve their quality of life by improving their breathing. So you can see this right upper lobe cancer in the middle of an emphysematous segment. You can take it out even if the patient's lung functions are bad. These are more complex types of lung resection, which we call sleeve or lung sparing resections. And these are very important when an MDT takes the opinion of a thoracic surgeon to tell them if he can spare part of the lung or not. And this may influence the decision on what's the best treatment for the patient. So in a sleeve resection, if the tumor is central, we can take part of the tumor out with a lobe and preserve the rest of the lung by making an anastomosis between part of the bronchial tree. A tumor like this. So this is a central tumor, and a classic operation to get rid of this tumor would be to take the whole right lung out, which is a pneumonectomy. But we can do something better. This is a complex resection. This is one of my patients. This is a double sleeve lobectomy. So in a double sleeve lobectomy, you take the tumor out with preserving part of the lung, but to preserve that part of the lung, you have to anastomose the bronchial tree again, and you anastomose the pulmonary artery together again. So this is a double sleeve procedure. I hope this works. So yeah, this is an intraoperative picture of a double sleeve, and you can see this is the pulmonary artery, main pulmonary artery anastomosed to the right lower lobe pulmonary artery. That's where the suction is. And that's the bronchial, right main bronchus anastomosed to the right lower lobe bronchus. So instead of removing the whole right lung out, we removed only half of the lung out, and that's the right lower lobe preserved. So this is a bit of complex surgery to preserve the lungs. Obviously, the advancement in thoracic surgery means that we can use smaller holes. So instead of the classic open surgery, we've got the facility now, especially for small peripheral tumors, non-central, non-nodal involvement, to perform a VATS lobectomy. So that's a video-assisted thoracoscopic surgery. And obviously that's less invasive, less hospital stay, recovery, you get back to work quicker. So yeah, instead of a 20 centimeter incision, we can use 3 or 4 centimeter incisions, and patients can usually be home within 48 hours. So just a quick glance at neoadjuvant chemotherapy. What's the virtues of having neoadjuvant chemotherapy? The theory is that you get good control of micrometastases. There's no surgery yet, so there's better blood supply to the area of the tumor. Could you need a lesser resection? Could neoadjuvant chemotherapy give you a chance to resect less from the lungs? And we'll get into that. You are reducing the tumor load, and you may assess the benefit from further surgery. So if a patient has neoadjuvant chemotherapy and he doesn't respond at all, you might reconsider whether he'd benefit from surgery if you give it prior to the operation. And these are all studies over the years assessing the benefit of neoadjuvant chemotherapy versus surgery alone. In a few of them you can see some survival benefit on the right. And the summary of evidence is that if you choose the right patient, and as we said in the beginning, these 3A patients are mainly N2 patients. So in N2 patients who you're going to treat by surgery, neoadjuvant chemotherapy can reduce the relative risk of death by 13% and improve 5-year survival rates by considerable amounts. And that's been published a few years back. And this is the other situation which I think there is good evidence to give neoadjuvant treatment. These Pancoast tumors, and they're not big trials, but they're 2 randomized controlled trials, and they've been published probably 15 years back, but this is what we base our work on, that patients who have Pancoast tumors, they could benefit from neoadjuvant chemoradiation, which gives you superior survival after surgical resection. And that's what we apply till today. But why not neoadjuvant chemotherapy? As I said, there's no evidence to support the benefit in patients not having N2 disease. And if you give the patient chemotherapy, his fitness on operating becomes debatable. And definitely what you saw from patients having complex operations like double sleeve becomes much more difficult. A surgeon's role is to get rid of the whole tumor, to achieve an R0 resection. And if you receive neoadjuvant chemotherapy, this is of a much more difficult goal, because you can't see margins and you can't feel the fibrosis that patients have after neoadjuvant chemotherapy. And the evidence to support adjuvant chemotherapy in nodal positive disease is much stronger than neoadjuvant. Yes, we believe that as you have advancement in nodal disease, the prognosis is worse, and that's why N2 disease is a debatable issue. But this is really important. This is an old trial, but I think a lot of our work, as I will show you, is based on this trial. This is the North American Intergroup 139 trial, and it was a large trial comparing chemoradiation with or without surgical resection for stage 3 non-small cell lung cancer. And they found that there's a 25% mortality if you receive neoadjuvant chemotherapy, followed by taking the whole lung out. So we think this is bad for patients, and we think if a patient is to receive an immunectomy, he should not receive neoadjuvant chemotherapy. This is our local protocol. And it's based on the bulk of evidence that I've just presented. So if you, just to make it easy, if you've got a stage 3 N2 patient, if the tumor is not resectable, then he will receive chemoradiation or chemoradiation followed by immunotherapy. If it's resectable, we're going to have a look at where is the tumor. If the tumor is in the left upper lobe, then we consider this N2 disease. If it's station 5-6 as an N1, and we go ahead and do an operation and we give them adjuvant chemotherapy. If it's a non-left upper lobe, we're going to see the extent of the N2 disease. If it's a single station, we have a look at the volume, is it bulky or non-bulky, and we have a look at what resection is needed. If the resection is an immunectomy, we don't do surgery. If it's a non-immunectomy, this is a situation where we consider neoadjuvant chemotherapy. If it's non-bulky, we go ahead and do an operation and follow that by adjuvant chemotherapy. If it's a multi-station or multi-zone N2 disease and it's bulky, we don't do surgery. If it's non-bulky and the resection is an immunectomy, we don't do surgery. If it's non-bulky and the resection is not an immunectomy, again, in an MDT, we could consider surgery followed by adjuvant chemotherapy. So, to sum it up, these are the patients where we consider neoadjuvant or adjuvant chemotherapy. Stage 3A patients, diagnosed radiologically as N2 or pathologically postoperative as N2. And again, you need to sit in an MDT and consider patient factors, preferences, what type of surgery does he need, and what treatment is best for him. I know this will be discussed later, but I think these are new trials, the NADIUM trial showing that the addition of immunotherapy in a neoadjuvant setting is promising and may improve survival. I'll conclude here that surgery for early stage operable lung cancer still carries the highest chances of cure, should always be discussed in an MDT setting. The application of more complex lung-preserving procedures can increase the scope of operable patients in non-small cell lung cancer. And the benefit of neoadjuvant chemotherapy in resectable non-small cell lung cancer is not very clear, except in N2 disease and Pancoast tumors. And finally, the addition of immunotherapy to neoadjuvant regimes may add hope to the rate of cure for advanced non-small cell lung cancer. Thank you.
I'd like to thank Professor Hani for this elegant, to-the-point presentation. And let me introduce Professor Muhammad Al-Nadi. Professor Muhammad is Professor of Chest Disease at Cairo University. He's the Director of Chest Unit at New Cairo University Hospital. And he's a member of the COVID-19 committee, scientific committee at Egyptian EMOG. Dr. Muhammad, please.
Bismillah ar-Rahman ar-Rahim. Thanks my dear Professor Ahmed for introducing me, and thanks to Eva for this nice, fruitful symposium. And I am greatly honored to be with you tonight. And I'm going to speak today about different topic. Pitfalls in management of COVID-19. What is the pitfalls in diagnosis and what is the pitfalls in management? This is my main topic to be discussed today. Okay. Okay, this is a picture of the French hospital, and we have an intensive care unit in the 7th floor. Including intensive care and a unit for bronchoscopy and thoracoscopy, and the inpatient and the pulmonary function also. My topic today is about COVID-19, and as you see in this slide, COVID-19 is a medicine, and I think the world before COVID-19 and after COVID-19 will be greatly different. What is the pitfalls in the diagnosis? Some recommend that you have to perform CBC and LDH and D-dimer and CRP to diagnose. And some recommend to do pulmonary function, and some recommend to do sputum culture and sensitivity. All of these not conclusive for the diagnosis. The diagnosis of COVID-19 is made just by two things: clinical picture plus PCR, or clinical picture plus high resolution CT. And the other labs or inflammatory markers is used just to specify the degree of risk or the severity of the disease. So the diagnosis is mainly made by symptoms, as you see: presence of fever, sore throat, headache, runny nose, shortness of breath, bony aches. But these symptoms share the symptom of common cold. Has the same symptoms regarding running nose, headache, sore throat. But if you find your patient tells you that he has abrupt, unexplained loss of taste and smell, this is COVID until proved otherwise. If the patient told you that he has a skin eruption, whatever its a site, it is COVID until proved otherwise. If your patient told you he has a swollen red eye, this is COVID until proved otherwise. So we have three great differences between influenza or flu to be differentiated from COVID-19. Sudden unexplained loss of taste and smell, skin rash, red swollen eye. Taking into consideration, many of our patients are asymptomatic, no symptoms at all, and these patients without symptoms can infect 50% of COVID-19 infections. Also, we have to be aware about the skin manifestation of COVID. At the start of this disease, our knowledge was little. So we were uncertainly about the diagnosis of this skin lesion, which due to COVID infection affecting the skin, such as erythema, or vesicle, or urticarial lesion, or monopocular eruption, or pseudovesicular affection, or ocular papules. Also, we have what's called COVID lung. When you inspect the COVID lung, you might find COVID ulceration, gingival inflammation, xerostomia, which is a common feature for the COVID-19 patient to tell you he has a dry mouth. Dry mouth is due to the usage of mask or due to salivary gland affection. COVID affects the salivary gland because the ACE2 receptor is distributed through the salivary gland mucosa. Also, we have cracked teeth. Also, we have loss of taste and smell. And these 5 top oral manifestation is unique for COVID-19. So, the diagnosis is made based on clinical plus PCR if it is available. And if you have no PCR and the patient developed respiratory symptom, you have to perform high-resolution CT, taking into consideration that PCR may be false negative. I mean, the patient has COVID, and in spite of that, PCR is negative because the swab carry 63% positivity, and some patients may have COVID, but the swab is negative. So, if the patient has respiratory symptom, it is better to arrange for high-resolution CT, which may show what's called the ground glass appearance, which reflect starting of the alveoli to be filled with a fluid. Then, if the alveoli fully filled with the fluid, it will give solid consolidation. And if the interstitium is swollen, it will give what's called the crazy paving. These 3 signs is very characteristic for COVID, which may occur in isolation or in combination, solid ground glass appearance or solid consolidation or crazy paving, 1 or the 3 or 2. Presence of pleural effusion in the past was against the diagnosis of COVID-19, but nowadays we find many cases with COVID with bilateral pleural effusion, but the presence of cavitation or lymph node enlargement is against the diagnosis of COVID-19. So, the diagnosis is just made by clinical plus PCR or clinical plus HRCT, and never to diagnose based on CBC or LDH or D-dimer or serum ferritin or CRP or AST or ALT. So, why you did perform this function? These labs just reflect the degree of severity to classify your patient, whether it is mild or moderate or severe or critical, whether you are going to anticoagulate or not, whether you are going to prescribe antibiotic or not, whether you are going to prescribe anti-inflammatory or not, but they are not at all diagnostic. It's just reflect risk stratification of your patient. Common mistake, you perform a D-dimer and you find this D-dimer is very high and you are prescribing the patient anticoagulation. This is a false knowledge because D-dimer increase after surgery, after trauma, after severe infection, after liver disease, in healthy elderly, in pregnancy. All of these factors increase D-dimer. So when you find D-dimer is increased, you have to justify the clinical background of your patient. So the follow-up will be made by PCR, clinical, HRCT, marker. No, there is no follow-up by PCR. PCR is used just for diagnosis, not just for follow-up. Follow-up will be made by clinical, by HRCT, by follow-up of the inflammatory markers. This is the first part of my lecture. The second part regarding the management. What is the mistakes made in management of COVID-19. Everyone have to be aware about this slide, which is called the master slide. Because if you don't understand what's going on, you are not justified to prescribe any medication. With early viral infection, there is what's called viral infection phase. This occurs up to 10 to 12 days from infecting the cell. Then after that, the body will respond by hyperinflammatory phase. So, it is of great value to prescribe antiviral early, and of no value if you are going to prescribe antiviral late. Antiviral late of no value. Antiviral early of great value. Anti-inflammatory early of great damage, great danger. Anti-inflammatory late is of great value. Okay. And we have a gray zone in between the inflammatory phase, which occur after 12 days, and the viral infection phase, which occur in the first 10 days. This is called the pulmonary phase. If your patient presented to you with hypoxia or without hypoxia in the period between 7 to 14 days, you are justified to combine both antiviral and anti-inflammatory. And the key success for any antiviral treatment is to start this antiviral early. If you prescribe antiviral late, which is a very common mistake, at least in Egypt, they are treating coronavirus infection using just antibiotics. And again, and again, and again, it is a viral infection. No one can treat viral infection by antibiotic. Viral infection should be treated by antiviral. Okay? So antiviral is prescribed in the viremic phase, and the anti-inflammatory is prescribed in the severe hyperimmune response phase, and in between you are justified to combine both of them. So we are justified the position of 4 antiviral, antibiotics, anti-inflammatory, anticoagulant. Regarding the potential antiviral, we have what's called potential antiviral because there is no specific antiviral up till now for corona. We have no specific vaccine up till now for corona. All of these are potential antiviral. Some of them has direct antiviral effect, however non-specific, as remdesivir and lopinavir, ritonavir. And some of them are not antiviral at all. One of them antimalarial, which is called hydroxychloroquine, and the other is ivermectin, which is antiparasitic. But the studies reveal a good effect regarding inhibition of viral multiplication. However, it is an indirect mechanism. Regarding this drug, which is called ivermectin, it shows very good results in Egypt, especially after the second protocol or after modification of our protocol in November. It acts by inhibition of what's called importin alpha and importin beta 1, which is called the cargo protein. This cargo protein is responsible for translocation of the coronavirus from the cytoplasm to enter the nucleus. And when it enters the nucleus, it will enhance the nucleus to sensitize the anti-inflammatory or to inhibit, to sensitize the inflammatory proteins. If you combine these importin alpha and beta 1 by ivermectin, so the coronavirus will remain in the cytoplasm without the capability to infect the nucleus and just inhibiting its effect regarding infection enhanced riposte antiviral activity. So ivermectin, in spite of being antiparasitic drug, it is of great value in reduction of viral multiplication and even in prevention of what's called post-COVID syndrome. Regarding the anti-inflammatory, the antiviral, which is called remdesivir, it is the only antiviral which could be given by intravenous infusion over half an hour to 2 hours. It is the only FDA approved drug and also EMA marketing authorization, European Medicine Agency. Single dose loading 200 milligram in the first day to be reduced to 100 milligram for 5 days, and if the patient is mechanically ventilated, you are justified to increase the dose up to 10 days, but when it is administered early, it will give more good result. And the many studies in Italian studies reveal its significant value when it is introduced early, especially in critically ill patients. And also in pediatric, you are justified to give according to the body weight if it is more than 40 kilograms or less than 40 kilograms, and the dose as you show in the slide. Also, regarding antiviral during pregnancy, the only which has obtained compassionate use is remdesivir. You are not justified to prescribe hydroxychloroquine or ivermectin or favipiravir. Favipiravir is absolutely contraindicated because it is teratogenic, whether it is in male or in female. And the National Institute of Health recommend against the usage of other antiviral, just remdesivir. And regarding the contraindication, just absolute hypersensitivity reaction. And you have to be cautious when you prescribe remdesivir not to be associated with what's called hydroxychloroquine, because it hinders its antiviral activity. Whether your patient is improved or not, don't give remdesivir more than 10 days. Oseltamivir, it is anti-influenza. You are not justified to give in COVID-19 except if you are suspecting the patient has also influenza in association with COVID. Once you diagnose COVID alone, you are justified to stop oseltamivir. This is the first entity regarding antiviral. The second entity, are you going to prescribe antibiotic in this patient or not? If you prescribe antibiotic with the hope it will act as anti-inflammatory immunomodulatory, yes. But if you are going to prescribe this antibiotic because it is an antibiotic, you have to fulfill the criteria of indication, which is the patient become febrile after a period of afebrile illness. You measure procalcitonin and you find it increasing. You measure CRP and you find it increasing in spite of decrease the level of serum ferritin, or if the patient develops solid bilateral alveolar consolidation in less than 24 hours. Or if you perform CBC and you find leukocytosis with shift to left and toxic granules, and the management of COVID with pneumonia, bacterial pneumonia, is the same as in management of community-acquired pneumonia without COVID. This is the indications of the antibiotic: rapid development of consolidation or local consolidation with leukocytosis and the reappearance of fever with increase in CRP or procalcitonin. The same management will be as in CAP without COVID. Low risk in patient and high risk in patient. High risk in patient, you have to combine beta-lactam plus macrolide or beta-lactam plus quinolone. And if you have low risk, you are justified to give monotherapy fluoroquinolone or combination therapy, beta-lactam plus doxycycline or beta-lactam plus macrolide. The third is the anti-inflammatory drugs. Are you justified to give corticosteroids? Oh, corticosteroids and viral infection will flare the infection. Yes. It will increase the mortality. Okay. It will increase the length of hospital stay. Yes. It may complicate diabetes. Okay. It may cause hyperglycemia. Okay. But it has great value if the patient develops what's called cytokine storm. So you have to introduce it early because it will differ in mortality. It will differ in mechanical ventilation. It will differ in organ failure. What is the aim of anti-inflammatory drugs? The aim of the anti-inflammatory drug is to decrease, is to modify is to make fine-tuning of the immune response of the body to the viral infection, not to produce more inflammatory cytokines, not to damage the body, okay? We have two drugs performing this job. One is corticosteroid, and the second is tocilizumab, anti-interleukin 6. And we have the study, Oxford study, which demonstrates the efficacy of dexamethasone. And this is our Egyptian protocol, which prescribe sterile steroid, methylprednisolone, sodium succinate. If the patient is mechanically ventilated, you are justified to give the dose 2 milligram per kg in 2 divided doses. And if he is inside the intensive care without mechanical ventilation, give 1 milligram per kg in 2 divided doses. If the patient is responding well and good, if he is not, you are justified to add tocilizumab. Tocilizumab is an anti-interleukin 6, which is increased in cytokine store. And if you target this interleukin 6, it will make more benefit, as you see, if it is introduced at its time after 12 days, or if the patient become markedly tachypnic or desaturated on room air, or if you estimate the PaO2 over FiO2 and you find it less than 300, you are justified to introduce anti-interleukin 6 after failure of methylprednisolone to control this hypoxemia and respiratory distress. It reduced the mortality, it reduced lung inflammation. But if you introduce the early, very dangerous. If you introduce it with concurrent chest infection, bacterial, contraindicated. If you introduce it with liver cell failure, contraindicated. So you have to introduce tocilizumab in its position to make great value for patient improvement. The last is the anticoagulation, and we have many doctors over-prescribing, and on the contrary, many doctors less prescribing anticoagulation. There is increased risk for thrombosis, there is increased risk for pulmonary embolism, there is increased risk for acute coronary syndrome and stroke and microvascular thrombosis, up to 31% increased risk of thrombotic complications due to PE. And this is a post-mortem pictures for many patients died from COVID, have DVT and the pulmonary embolism, and during radiology, filling defect as you see, and when they perform what's called angiovac, this is the clots aspirated by mechanical thrombectomy. What do you mean? I mean that you are prescribed anticoagulant based on clinical, if your patient is distressed or desaturated on room air, or have rapid development of tachypnea, or marked deterioration of radiology, or you estimating the D-dimer and you find it more than 0.5. More than 0.5 and less than 1, you are prescribing to give prophylactic anticoagulant. More than 1, you are going to prescribe full anticoagulation in a therapeutic dose. Be careful that antiplatelet is not sufficient at all to guard against pulmonary thrombosis. Antiplatelets is just antiplatelets, but in COVID-19 you are in need to anticoagulant, not antiplatelets. If your patient inside the hospital, in the intensive care, you are justified to give parenteral anticoagulation. If he is on the ward or in the home, you are justified to give oral anticoagulation. If you prescribe oral anticoagulation, you are justified to give rivaroxaban or apixaban. If he is inside the intensive care on mechanical ventilation, you give him therapeutic anticoagulation, fondaparox. If the patient has heparin-induced thrombocytopenia, or if he has not, you are justified to give him enoxaparin sodium. Taking into consideration in a pregnant woman, you are justified to give low molecular weight heparin. Direct oral anticoagulant is contraindicated, and warfarin also is contraindicated. My last 4 slides. The good physician treats the disease. The great physician treats the patient who has the disease. I want to mention that. Your patient has a corona. You are treating the patient with corona, or you are treating corona in your patient. You are treating a patient with corona. This is very important. This patient has many organ failure, has many clinical problems you have to solve while you are treating your patient. Regarding Covet pneumonia, you have 2 subtypes, L type and H type. L type is very light, good compliance. You have to wait until your patient improve, and you have to delay mechanical ventilation. This patient, which is the one who developed ground glass opacity, but if he developed solid consolidation, this is called H type. H means heavy. Heavy means that the lung is bad, compliance is very bad, he is in need for mechanical ventilation with what's called lung protective ventilatory strategy. You have to decrease the tidal volume, and you have to increase the PEEP, and you have to be very careful regarding this patient because he is in ARDS actual. If your patient is tachypnic and desaturating, you are justified to improve his oxygenation using high flow nasal cannula or Venturi mask or non-invasive ventilation, whether using full face mask or helmet mask, or if you fail, you have to endotracheal intubate your patient and mechanically ventilate it. In summary, if you have a mild case means symptomatic patient without clinical manifestation of pneumonia, you are justified to prescribe hydroxychloroquine or ivermectin or favipiravir in conjunction with zinc and vitamin C and lactoferrin. Okay. In moderate case, you have to combine hydroxychloroquine and ivermectin, or if your patient has comorbidity, you are justified to give remdesivir. This is regarding antiviral. Regarding the immunomodulatory and anti-inflammatory, if your patient is distressed, please add steroid. And regarding anticoagulation, if more than 0.5 and less than 1, give prophylactic, more than 1, give therapeutic. If your patient is severe means that he is tachypnic, desaturated, developed respiratory chest abnormalities more than 50% increase over 24 hours, you are justified to start remdesivir immediately, early, to give good response, and the anticoagulation prophylactic according to the level of D-dimer, as I said. Anti-inflammatory, tocilizumab, you are justified to increase if the patient is responding on corticosteroids, and convalescent plasma if it is available. If this patient, in spite of this medication, particularly oxygen, doesn't improve, you have to turn this patient in the intensive care, which is critically ill, and you have to start remdesivir, lopinavir, and you have to give therapeutic anticoagulation, whatever the level of D-dimer, and you have to initiate steroids, and if your patient doesn't improve, you have to start tocilizumab to improve the immune response and to decrease the inflammatory cytokines, and thank you.
Thank you, Professor Mohammed, for this presentation. Let me introduce our next speaker, Dr. Ahmed Hassan. Dr. Ahmed Hassan actually is my senior. He's consultant oncology at Faculty of Medicine and Shamsi University. He's a visiting consultant at NHS UK. He will give us a lecture about the molecular marker and the decision making in lung cancer. Entitled Tissue was gold, now it is platinum, how to use the molecular markers in lung cancer treatment. Dr. Ahmed, please.
Thank you, Ahmed, my friend and my colleague. It's a pleasure to be here today. And I'd like to thank the EMOG group interesting sessions. Today I'll be talking through my talk is entitled How to Approach Molecular Markers in the Decision Making. Well, actually, when I was a trainee, we didn't have to bother about this at all. Life was so simple. If it's a lung cancer, the answer is cisplatin and etoposide. You don't have even to bother about whether it's small cell or non-small cell lung cancer. So we used to sit in the clinic with our seniors, and a patient walks in. So if the patient is small cell lung cancer, they say vepsiplatinol. If a patient is non-small cell lung cancer, regardless of adeno or squam, then it's vepsiplatinol. But the results were quite modest, and the survival we were attaining with such a combination was around a year, at best 14, 15 months. So there were continuous efforts to improve the results, and I'm bringing here a seminal paper by Scagliotti, which was published in 2008, where they were testing different combinations of chemotherapy in non-small cell lung cancer. In fact, in this study, they were asking two questions in one study. The first one is, what's the optimal combination for chemotherapy? And the second one, is there a difference in response between squamous and adenocarcinoma? And at that time, we started to see a difference in the biology between squamous cell and adenocarcinoma. And we've seen that if you use pemetrexed with cisplatin in adenos, you obtain better results compared to gemcitabine, and with squamous cell carcinoma, it was the other way around. And afterwards, for the following few years, the question also lingered on what's the optimal combination, but we were always playing with chemotherapy, substituting this for that, until we settled on the standard of care, and this is doublet chemotherapy, platinum-based, so the backbone is always a platinum, be it a carboplatin or cisplatin, and then you can use one of the first or second or third generation chemotherapies. Things have changed dramatically with better understanding of the disease biology and the molecular pathways. We have had a breakthrough in the management of lung cancer. If you look at this slide, we have nearly 30 new agents that we can use nowadays. Of course, it's a big burden to catch up with the data emerging every month and sometimes every week. But there are two main advantages here. The first one is seeing our fellow colleagues, the cardiothoracic surgeons and the respiratory consultants sitting in the MDT, struggling to pronounce these names. It's enjoyable to see how they say, for example, atezolizumab or ramucirumab. We can play with this over dinner later on today. But the second main advantage is seeing improvement in the outcomes, in patient outcomes, not only in terms of survival, but also in quality of life. Most of these agents are tablets and oral, and even the ones which are not available in oral form, they have a better, they come with better quality of life and less toxicities than chemotherapy. I was reading a paper recently, and it's interesting because actually it looked in a retrospective manner at patients treated in America in multi-centers with any targeted therapy, any immune therapy, and they looked at this whole cohort or whole group compared to conventional chemotherapy. And if you look, all of these patients treated with all these fancy new, not very new now, but all of these targeted treatments, the average survival was around 4 years. Those who were treated with a classic chemotherapy, a doublet platinum-based chemotherapy, the average survival is 1.5 to 2 years. So we managed to double the survival figures in addition to an improvement in quality of life. So how do you approach these targeted treatments? what's the optimal approach? Well, you'll find many diagrams and many algorithms. I brought here a simple cartoon which I practically use, and most of the oncologists nowadays use this approach. And the first question to start with is, does it have a driver mutation? And it's important to differentiate between a driver. Why is it called a driver mutation? What's the difference between a driver mutation and a carcinogenic mutation or an oncogenic mutation? Well, an oncogenic mutation is the mutation which transforms a normal cell into cancer. But a driver mutation, it does not only transform the normal cell into cancer, but it also puts the cell into a continuous on position. So, in essence, it makes the cell proliferation, division, and growth is addicted to the protein encoded by this gene. So it's not only necessary for the transformation, but also to evade apoptosis, to evade the immune system, and to continue proliferation and become immortal. So the first question is, does it have a driver mutation or not? I'll start with the easier bit first. If it doesn't have a driver mutation, what next? What next you have to ask, does it express PD or PD-L1? And for those who are attending this session and not very aware of the PD and PD-L1, these are markers telling us that the tumor, the cancer, can be treated with immune therapy. So essentially, a cancer cell has the ability to evade the immune system in a way that it can escape the immune system or immune system. So using immune therapy, which is not actually an extrinsic immune bodies, but it rather uncover or unleash our innate immune system to attack the cancer. So the question is this tumor overexpressing PD or PD-L1 or not? And if it is overexpressing this marker, by how much? So we know from literature that there are two significant cutoff points, the 1% and the 50%. And we've known that if the tumor is overexpressing the PD-L1 by more than 50%, we can use immune therapy very effectively and attain very good responses and improvement in survival. But the challenging thing for pathologists, and in fact is very frustrating to us as oncologists, is that for each immune therapy, you have a particular compatible diagnostic partner antibody, which is very confusing. So if, for example, you look at the data on nivolumab, you find that they used the DACO system and the antibody was the 28-8. If you look at the atezolizumab, they used the Ventana, the Roche product, and they used the antibody SP142. Pembrolizumab, despite being a DACO, but the antibody is different, 22C3, which is very confusing and very frustrating, really. But most practitioners or most consultants, they just look at the cutoff value, the 50%, which is the most significant cutoff number. And a couple of notes on the PD-L1 testing. It's always immunohistochemistry. This is the standard of care, and it is always performed on tissues. You cannot do it on liquid biopsies until date. And if you have a patient coming to your clinic and asking you, what is the likelihood of me testing positive for PD-L1? It is roughly 60%. And you can say that half of these roughly will be overexpressing PD-L1, around 30%. So if the patient has no driver mutation and is overexpressing the PD-L1 for above 50%, then we can offer immunotherapy as a monotherapy alone. You can get very good results, very good outcomes, and you can avoid the toxicities of chemotherapy. And I will not go into the details of that because my colleague Dr. May will elaborate on that in a few minutes. If the patient is positive for PD-L1, but this is less than 50%, you still can use immunotherapy. However, chemotherapy is essential. It is still the main player in the treatment. This is the NICE guidelines. This is the scheme from the NICE guidelines. And essentially it mentions the same. If you have PD-L1 positive more than 50%, then you can use immunotherapy alone. However, in a certain subgroup of patients, even if you have an overexpression of PD-L1, chemotherapy still has a role, particularly those with high volume disease or with impending organ compromise, where you want to attain a very good and very profound response in a short period of time, so you're after response rates rather than only survival figures. And again, if PD-L1 is positive but less than 50%, you have to use chemotherapy still. So what if you do have a driver mutation? Before I jump into the options and treatment options, different mutations, I'd like to just touch upon a few concepts, a few facts. You have to test all of these patients. You have to test all of the stage 4, all of the advanced adenocarcinomas. You have to test all of those non-small cell lung cancer not otherwise specified. It's not a luxury now. It is optional in squam. It is optional in adenosquam. It's not mandatory because the likelihood of observing these mutations is much, much less in the squam or adenosquam. But if you have this option, if you have funding to test in squam, particularly in certain subgroup of patients like the young, the never smokers, the females, then ideally you should be testing it as well. In the early stage, there are very recent data to tell that there is superior outcomes if you introduce some targeted treatments. It's not yet approved, but in the very near future, I anticipate we will have targeted treatments in the early stage. And sometimes actually it is important to test while you have ample tissues. Molecular testing. So which technique to use? Immunohistochemistry, in situ hybridization, polymerase chain reaction, gene sequencing, and if you have this facility at your place of work, what should you sequence? A panel, exome, or whole genome? Well, you have to have a practical, pragmatic approach. Do you have these tests available? Which ones of these tests is available to you? I mean, in my practice, I don't have access to next generation sequencing or even classic sequencing techniques. And the second question is not only about availability and practicality, but about being realistic. Do you have the treatments or not? So for instance, there is no point of me sitting in the Mirdash hospital and asking for an NTRK gene fusion or mutations, because I know that there is zero chance in the next 10 years of me obtaining Vitragvi, for example, for such a patient. So it's really not logical, and there's no point of testing for some mutations when you know that there is no chance of obtaining such medication for your patient, at least on the short term. Turnaround time. Optimally, this should be within 2 weeks or even a 1 week. And cost, of course, is very important. And now, thankfully, we can at least obtain the two main testing on the two main mutations, EGFR and ALK, free of charge by the manufacturer of the targeting agents. This is the scheme, the nice scheme for how to approach molecular testing for a driver mutation. So, and I always see that the NICE guidelines are more applicable to us in comparison to the American guidelines because it's more cost effective. So here they're testing for the essential panel, which involves the EGFR, the ALK, the ROS1, and T790 mutation upon progression on first-line TKI. And very recently, with the COVID pandemic, they started also funding for BRAF V600E mutation. But there are another additional tests for which there are approved therapeutic options. I've just mentioned the BRAF V600, and also you have very recently, probably last month, treatment for MET exon 14 skipping was approved by Concomitant, and also NTRK if you have access to this and if you have access to the treatment. Other targets which are still being tested and investigations are HER2/neu, BRCA1, RET, and NRG1. And for those who like the NCCN, if you look at the NCCN, they are also concurring with the NICE guidelines. So everyone with adenocarcinoma, everyone with large cell carcinoma, non-small cell lung cancer should get tested. And here it's more comprehensive than the British approach. They test for EGFR, ALK-ROS1, BRAF, NTRK, MET, exon 14 skipping, and RET as well. If you're squam at the bottom of the slide, then they say, if you notice the wording, they say consider molecular testing, particularly in certain subgroups that I've just mentioned a minute ago. And a couple of words on liquid biopsies. So essentially liquid biopsies are blood samples in which we look for DNA from cancer cells, because most of advanced cancers, they do shed some DNA or damaged cancer cells into the bloodstream. It's not always the case, but in most cases, in roughly 70 to 80% of patients, you'll find segments of tumor DNA in the bloodstream. The advantage of liquid biopsies is, first, it's convenient, just a blood sample. You can obtain it in 5-6 seconds. The second thing, it's a non-invasive procedure. You can do it several times looking for different targets. And actually, some research groups are now using the liquid biopsies to look for signs of response, to look at the volume of the circulating tumor DNA and whether it reduces with systemic treatment or not. It's a rapid test, and it has a very high specificity, meaning that if it tested a patient positive, then this patient is definitely a positive cancer patient, positive mutation. However, as I said, the sensitivity is compromised, so it's only around 70%, so there is a chance of missing around 30%. This morning I was giving another talk on lung cancer, and I was demonstrating a case with the stage 4 with multiple metastases and heavy volume disease. And despite having a large burden of disease, yet the several tests for circulating tumor DNA via liquid biopsies were negative. So you have a high chance of having a false negative test. Also, the technique, it needs training and quality assurance. And you cannot perform PDL testing on it, as we said. It has to be tissue for PDL1 testing. Thank you very much.
Thank you, Dr. Ahmed. As we said, inshallah, the discussion will be at the end of the session. Let me introduce our next guest speaker, Dr. Mai Azzeddin. Dr. Mai is Assistant Professor of Clinical Oncology at Shams University. Dr. Mai will present for us today innovation in immuno-oncology, the non-oncogene addicted lung cancer. Dr. Mai, please.
It's an honor and pleasure to be here today. I'd like to thank Professor Ahmed Gaballah for giving me a chance to be in this prestigious gathering, and hello to all our friends and colleagues at home and professors. And this is the title of my talk. And this is just, the curves, survival curves for lung cancer according to the 8th TNM. And this is the part we are dealing with in this talk here, stage 3 and 4. And I'll try to go swiftly through stage 4 and stage 3. As you see, the survival curves are not that encouraging. It's really needs a lot of work. And that was it? Okay, so here, as we can see, at best stage 3A, according to this data reported from the TNM Atlas in 2016, at best it was 36% survival, and with stage 4B it was hit rock bottom 0. And just to have a bit of background, and as mentioned in the previous talk by my colleagues, of course, from the early data in the 2000s, we had Kelly and Schiller's data. We had a median survival in the range of 8 months, and 1 year survival was quite dismal at 30-something%. And clearly new strategies needed to be pursued, and pursued they were. So we know the data from Scagliotti, pemetrexed having a more favorable outcome in non-squamous, cisplatin being equal to carboplatin, perhaps 4 cycles is better than is equal as effective as 6. And even with that, we tried to squeeze some more effects through maintenance approach, either by bevacizumab or pemetrexed, just about hitting the 1-year survival mark. And unfortunately, this seemed to be, we were running quite dry until a glimmer of hope and lights came with the introduction of immunotherapy to us, the 2 synapses that we know now, PD-1 and PD-L1 ligand, and CTLA-4. And really, this has revolutionized the way we look at lung cancer. It's not just histologically based, but we also know that we have, of course, as we've just seen, the oncogenic drivers for disease, but still the larger portion of patients remain undruggable. And KRAS, perhaps quite soon, I hope we'll have something to be targeted with, but still we still have quite a hefty percentage do not have any drivers. And thus we are starting to look at PD-L1 and tumor mutational burden and other markers just to have an idea about the immune signature of the disease. And why is that? Because of the early data by Checkmate 003, because we're interested in the tail of the curve. We're seeing durable responses. We're seeing 5-year survival rates, as I remind you, was 0. Now we're some 16% of patients are still surviving, and this is, of course, quite a positive signal worth pursuing. But PD-L1, although it is a validated marker and is the marker that we are using, it's still, it is the imperfect biomarker, but it's the best we have. Why is that? Because the innate nature of tumors is to be heterogeneous. So as we can see here, just through this biopsy sample, it depends which part of the tumor you are sampling to get your readout. And of course, the other point that I would like to stress on is that it is cutting in sort of in a biologic continuum. You don't have a yes or no answer. It's not white or black. It's sort of shades of gray. And it can be affected by the microbiome. It can be affected by therapy. And some have even tried to augment the effectiveness of this therapy by, for example, in Checkmate 227, by associating it with tumor mutational burden. And unfortunately, as you can see here, PD-L1 expression over 1% was 71%, either more than 10 or less than 10 tumor mutational burdens per megabase. It is the validated, it is the best marker we have available, and I would like to quote this of the great pathologist Keith Kerr, who said, it's sort of like skiing off a piste. It's quite attractive, but it can be still potentially dangerous. And here are the drugs I'll try to go through. I hope you can bear with me. The PD-1 inhibitors, nivolumab, pembrolizumab, and the new kid on the block, cemiplimab. CTLA-4 inhibitors, ipilimumab and tremelimumab, and PD-L1 inhibitors, atezolizumab and durvalumab. And these are the approaches that we usually pursue. Either you can give IOs as solo therapy, or you can give them in combos with a chemotherapy back-based or IO-IO. And the other points I'll be discussing at the end of stage 4 disease is other approaches, and just try to quickly tie some loose ends. Monotherapy, of course, usually we set the scene in the second-line setting against standard of care docetaxel. And here are the trials. As you can see, Checkmate 017 was devoted to squamous cell carcinoma, Checkmate 57 for adeno or non-squamous. Keynote 010 and OAK were for pembrolizumab and atezolizumab, respectively. All had positive hazard ratios in the range of 0.6 with the squamous and 0.7 ranges, more or less, and all had median overall survivals in the range of 1 year, or a bit more than 1 year. This is second line. Some of these patients were heavily pretreated patients. To see this median overall survival in pretreated patients was something quite remarkable. And all did not request a PD-L1 selection except for the Keynote 010. And as the PD-L1 signal was stronger, the patients did seem to benefit more. As you can see with the smaller hazard ratios, the shift to more favoring the immunotherapy. But this did not negate the fact that actually some PD-L1 negative patients did also, overall, the patients did benefit. And here really was the time for the big paradigm shift as immunotherapy was being leveraged and lifted up to the first line. And this is the Keynote 024, more valuable than platinum. Also, finally, something was breaking through the platinum doublet. We were seeing here a hazard ratio of 0.63, 30 months versus 14.2 months, doubling of the median overall survival. This was something unprecedented before in lung cancer. And this is the latest update from just the last ESMO 2020 by Professor Julie Brammer. And 5-year survival was doubled, 31.9% versus 16%, and still same hazard ratio, 0.62, despite a 66% effective crossover rate. 55% of the patients crossed over to pembrolizumab, and the remaining received other immunotherapies off study. So this was definitely a good way to go, and it was a positive trial, and it showed a great glimmer of hope. What about sorry, I forgot to mention that Keynote 024 was restricted to patients having PD-L1 in excess of 50%. But what about those who are less than 50%? What should they do? And so Keynote 042 addressed this pressing question, and it included patients who had a score of in excess of 1%. And again, monotherapy, a positive trial, essentially hazard ratio 0.81. But as you can see, the main driver for this good result, or this impressive result, was the PD-L1 subset over 50%. And not even just that, this was also echoed in other studies. This is a retrospective French study. Not only that, but even the patients over 50%, the subset of patients who have more than 90% seem to have stronger, smaller hazard ratios and longer median overall survivals. And this is an interesting study done by the great Professor Roy Hurst, and he took sort of a combo from the Keynote 010 and Keynote 042. So these are patients that are PD-L1 positive. And he tried to find which patients, if you could correlate those, which benefited most from immunotherapy by correlating that to tissue tumor mutational burden, more than 175 mutations per exome. And he found that patients who had this high tumor mutational burden with, of course, the PD-L1 in excess of 1%, seem to benefit more than with immunotherapy than chemotherapy, whilst those who didn't, as you can see, the curves are just overlapping. Now we come to our, second immunotherapy, again, Empower 110 with atezolizumab. And here we see that the interesting thing about this study was that again, it actually took all PD-L1 status, but it only was overall, it was a positive study. It had a good hazard ratio of 0.59, but it did not meet the overall survival benefit with a low hazard ratio. With a low PD-L1 signal, TC1, 2, or 3, which basically means low PD-L1 reading. And the interesting thing also about this study is that it took the different assays we used to measure PD-L1, whether SP142, 22C3, SP263, and it seemed that all three assays gave almost 20 median overall survival and also similar hazard ratios, 0.6 or 0.7. And this was also echoed with the low subgroup. Now to the final monotherapy, cemiplimab Empower Lung 1 trial, just presented this last ESMO, and we can see here it was initially recruited 710 patients and was reported also on the 710 patients and a smaller subset of patients because of some regulatory authority, they had to repeat the PD-L1 testing. The interesting thing about this new trial, it is actually a Me Too trial, but it it included other areas of the world, Europe, Asia, and the rest of the world. So it's sort of a real world population, different populations, different ethnicities. And it was a positive trial in the intent to treat, and even in the PD-L1 more than 50%, despite also the very high crossover rate of 74%. Now for one of our combos, the Io combo. Checkmate 227, nivolumab and ipilimumab, one of the most famous combos in immunotherapy, and we'll be discussing part 1A trial, those who have a PD-L1 expression over 1%. And we can see here the combo versus nivolumab solely versus chemotherapy. Positive results, 17 months versus 14.9 months for chemotherapy. Only for the combo, nivolumab did not reach significance, and the progression-free survival was also positive, but not as impressive. And even despite a 76%, this is a 3-year update for the patients over 76% crossing over, still it remained positive and preserved its hazard ratio, again for the combo of nivo and ipi and not for nivolumab single agent. And this was, of course, more pronounced. Instead of 17 months, it was 21 months with a tighter hazard ratio for those having even higher PD-L1 expression. This is just, just going to mention the MYSTIC trial, durvalumab and tremelimumab trial, and it was essentially a negative trial. The authors tried to find some sort of, reasoning by tumor mutational burden. I'll be touching on that near the end of my talk. Now for the second kind of combo, the Chemo Io Combo. And here the famous Keynote 189 trial, which included only non-squamous patients, and it gave platinum with pemetrexed, and as we can see, hazard ratios halving the risk of death, with 20% improvement on 1-year survival rates. So this was really a great answer to the question, the pressing question of what should I do with patients having more than 1% if they are not doing so well on monotherapy. So I can add chemotherapy, of course. And this is the Empower 150 trial. Again, atezolizumab with carboplatin paclitaxel with something new, a VEGF, bevacizumab. And the interesting thing about this trial, though they were not included in the final analysis, is that patients having EGFR or ALK aberrations that had progressed or were intolerant to therapy were included actually in this study. And here we see the population, a positive hazard ratio of 0.78 and improvement almost 5 months. Here is another Empower 130. Atezolizumab with carboplatin and nab-paclitaxel. Some have used, we don't really use nab-paclitaxel that frequently in lung cancer, but some have advocated that this trial can be an alternative if the patient, if you're going to use atezolizumab and you cannot, the patient is intolerant or cannot, has a contraindication to the use of VEGF receptors, bevacizumab. This is Keynote 407. It is the squamous part for pembrolizumab trial. And of course, we use the chemotherapy carboplatin paclitaxel as the backbone here. And again, it was quite a positive trial with a impressive hazard ratio of 0.64 and an improvement almost of reaching 6 months. This is an interesting analysis done by Professor Luis Pazares, and he sort of combined all the patients from the Keynote trials, Keynote 021G, 189 and 407, the squamous and non-squamous, and the phase 2 trials. And he took this analysis and he took the tumor proportional score less than 1%. And despite that, these patients still did well with immunotherapy, 8 months improvement, and had a very impressive hazard ratio of 0.56. So this was something worth mentioning. For PD-L1 less than 1% patients, we have part 1B dedicated in Checkmate 227 with nivo-ipi. But here we do not give, of course, nivolumab as a single agent. We must combine it with chemotherapy. And the surprising thing was we would have expected that chemotherapy with nivolumab would outperform only immunotherapy. But it seemed that the nivo-ipi combo here outbeat the nivo-chemo. And so still the significance, 0.64, was for the combo and not for Nivo and chemotherapy versus chemotherapy. But despite this result, the FDA approval stood with Nivo-Ipi regimen for patients having a PD-L1 expression more than 1%. Other approaches, well, Checkmate 9LA also approved, regulatory approval. This is sort of the dual-duet Nivo and Ipi with only an abbreviated 2 cycles of chemotherapy, not the usual at least 4 or 6. And again, positive hazard ratio 0.66 and an improvement from 15.6 versus 10.9 months. This was unfortunately Canadian durvalumab tremelimab trial. It was a negative trial essentially, and unfortunately. Just going to try to, tie a little bit of loose ends before I just briefly mention stage 3, the EGFR question, the PD-L1 tumor mutational, and perhaps are there any markers that can tell us if immunotherapy is effective or not? So we know inherently that if you have something like EGFR or ALK or ROS, or there are targetable, druggable targets. So these patients, even if they do have a PD-L1 positive signal, they do not do well with immunotherapy. In fact, even the early trials were closed due to futility in these patients. And not only that, but it seems by using these patients in sequence, using immuno followed by these targeted or vice versa, these patients had more worse side effects. Perhaps there was a signal of hope for this trial, the bevacizumab, the Empower 150 regimen, but the number of patients in EGFR was 108 patients, and the ALK 34 patients cannot really reach any conclusions. Some have favored this regimen for these patients if they, of course, progress first on EGFR or are intolerant to it. But this is only based on progression-free survival. Finally, all were awaiting the overall survival data for this, and it was actually reported just this last ESMO by Martin Reck, and they said you may use this regimen, you may, because as you can see, the hazard ratio is 0.6 and it has crossed the boundary of 1. So no overall survival signal here. What about the PD-L1 tumor mutational burden? Well, I've mentioned that MYSTIC was a negative trial. They tried to reason with tumor mutational burden, saying that this signified the strength of their duet, and patients that had more than 20 benefited from this regimen. Well, what about Nivo-Ipi, Checkmate 227? As you can see here in this red box, you had it low, you had it high, you still benefited. So was no signal here. The as was for the Keynote 189. Tumor mutational burden did not show any sort of consistency between effects. Efficacy markers, well, we know there are some possible mutations, KEEP markers, or STK11, LKB. Some were identified from retrospective studies, and they had different cohorts of patients, and it seemed that patients who harbored these mutations did worse on immunotherapy than patients who did not have these mutations. We have also this precision immuno-oncology for advanced non-small, or the Pioneer project, presented also last ESMO by Professor Fabrice Barlesi. They're trying to form sort of a immunogram to help guide us if the patients will benefit from immuno, single agent, immuno combo, immuno with chemotherapy. It's still a work in progress, but very commendable and innovative work indeed. Not only that, there is also the Battle trial. Same idea, really precision and personalizing care in lung cancer, the lung matrix trial, and also the US-based lung map schema, also taking precision medicine and lung cancer to a new level. So I've completed stage 4. Now just briefly, I'll just mention stage 3, the rationale for immunotherapy after concomitant chemoradiotherapy. Of course, radiotherapy may release the new antigens. The immune system should interact, but if it is inhibited, so if we give immunotherapy, we are unveiling or releasing the brakes, as they usually say. And this was the idea, the rationale. The Pacific trial did not request any sort of PD-L1 level. Patients had to receive at least 2 cycles concomitantly with radiotherapy, and they received durvalumab for 1 year, and they had to be assigned to respective groups within a period of 30 to 45 days. Progression-free survival was definitely positive, tripled almost, with hazard ratio 0.52, and the survival was almost doubled. Progression-free survival, all parameters was improved, and we're seeing a difference of 1 year between the two groups. And this is also up to 3 years, the median overall survival was not even reached, and it seemed to decrease the percentage of patients developing a brain relapse. So that was something interesting. You know, your immune cells can travel, they can cross the blood-brain barrier. And this is the last report for durvalumab, the Pacific trial. And finally, capping off the median overall survival at 47.5% versus 29.1% with a hazard ratio of 0.71. Progression-free survival, also hazard ratio of 0.55, still tripled. And FDA gave it an all-through yes, okay. The EMA requested a sort of a post hoc analysis on the PD-L1 question and gave it approval only for patients who have a PD-L1 in excess of 1%. Although the trial, I remind you, it was not designed to answer that question. So in the end, checkpoint inhibitors, of course, as we can see, have become first line. They are standard treatments that should be employed. Still, we do need some fine-tuning, some fine adjustments to find the best biomarkers to tell us and guide the way. And the standard of care for stage 3 non-small cell lung cancer is, of course, concurrent chemoradiotherapy followed by consolidation durvalumab. And taking that from the Pacific Ocean, spreading to wider oceans, as the previous talk by Professor Hani Hassan mentioned, the perioperative setting for immunotherapy really have, in fact, some results are starting to come up. Many results are scheduled this year, but positive data has just been reported, but not yet officially read out. So we must ask ourselves a question: is it time to finally stop saving our best for last? Well, we will change the adage, because they usually say, the wise saying goes, save the best for last, but really we shouldn't. And thank you so much for your attention.
Thank you, Professor Mai, for this elegant presentation. I'd like to ask all the speakers, please, to join us in the floor to reply for the questions we receive from the audience. I'd like to highlight that Professor Salam Shehri apologized for the meeting for an emergency situation. I hope he will be got soon. So we'll start the discussion now. We will receive the question on the Zoom. Please send your questions on the Q&A section, please.
We have a first question. Is PD-L1 specific for lung cancer? No, it's not specific for lung cancer. We've been using it also in other types of cancers. In fact, in many other types of cancer, you don't have to test for PD-L1 because we know that there is an immune response or a response to immunotherapy regardless of the PD-L1 score. And when I mentioned in my talk that a clinically significant cutoff value is of 50%, this only applies to non-small cell lung cancer. We have other significant cutoff points for other cancers. For instance, in breast cancer, the cutoff is 10%. So above 10%, immunotherapy is highly effective. Less than 10%, we don't have evidence on that. In small cell lung cancer, in TCC, bladder, in hepatocellular carcinoma, we don't have to test for PD-L1. So it's not specific for lung cancer. And we've been using immunotherapy now for a wide array of cancers. Dr. May?
Just completely agree.
Apparently, there are no further questions, so I would like to thank all of the audience and attendants for attending this session, and I'd like to thank the EMOG group for the great organization for this event. Thank you very much for getting us together. And we have a question actually from the speaker, Dr. May, Professor May. To whom?
Dr. Mohammed do you advise cancer patients to take the vaccine? The available vaccine is the...
It is a tricky question.
On follow-up, it's different phases, so I'm not really quite sure.
This is a very important question regarding the Chinese vaccine. The Chinese vaccine is a vaccine which is prepared by the traditional method. So, regarding its technology, it is an old technology which is safe and convenient, as the virus is heat inactivated vaccine or killed vaccine. So it is prepared in a traditional fashion. So its safety to use agree 100%. If we compare it with Moderna and Pfizer-BioNTech, which depend on messenger RNA, which is a recent technology, no one can guarantee what's going on regarding this messenger RNA and what is the order to the nucleus regarding this messenger RNA. The safest is to use the China vaccine. Not because it is the only available vaccine in Egypt, but because it is the traditional method to give any patient the vaccine. Regarding the cancer patient, I think the cancer patient in particular in need to obtain good immunity. And this patient in particular, if he is receiving chemotherapy or radiotherapy, he has some sort of immunosuppression. So he is at high risk to get the infection. So we advise this category of patient to receive the vaccine just after medical stuff.
Can I comment on this as well? There's been some reports, particularly coming from the UK, addressing this. There are no major concerns in terms of side effects or toxicities in cancer patients. However, they were questioning, and we don't have a solid answer for this, they were questioning the effectiveness of the vaccine in this group of patients, because as Dr. Mohammed has just mentioned, their immune response is compromised, so you wouldn't expect the same kind of reaction or rebounds as in a normal individual. They're also conducting a very interesting study on cancer patients where they're testing two different, instead of giving 2 doses of the same vaccine, they have started now testing the first dose from the AstraZeneca one, the Oxford one, and the second booster dose is the Moderna or the Pfizer one. So.
And the second dose is questionable regarding the AstraZeneca vaccine, because you choose to give the genetic component using chimpanzee adenovirus. This chimpanzee adenovirus is innocent antigen. If it enters the body for the first time, it will not be attacked by the immune system. But if you are going to give the second dose, the immune system may recognize it and may attack it. So the advice is to use the second dose, such as Sputnik vaccine, the Russian one, using the technology of modified genetic technology using a genetic vector, not adenovirus, so as to protect it from the immune response from the second dose. If you give the chimpanzee adenovirus for the second one, the body may stimulate the immune response to attack the second dose, as the patient may gain no benefit if you give him the second dose.
Thank you. And final question to Dr. Gabala. Are you going to have the vaccine, Dr. Ahmed?
I will brace the khara, inshallah. I didn't make my mind yet.
Good political response.
Thank you, dear colleagues and dear professors, for this elegant, nice presentation. I hope we can continue with this continuous medical education always. Inshallah, I'll wait for you all in our next meeting, inshallah, next month about immuno-oncology and cancer management. It will be in the 25th and the 26th of March, inshallah. Thank you all, and I hope you have a nice day. Thank you.